of these fractures around the hip.
And post-operative patellar pain and subtrochanteric fractures are prone for malreduction that way. And if you have any doubt in malreduction intraoperatively, never hesitate to open the fracture, and preservation of stability is very, very important. And at the end of check, always check the rotation and malalignment. Thank you so much.
Thank you, Dr. Bangarswamy garu. Time is next. Dr. Kasha Srinivas should deliver his lecture on tips and tricks of reduction of fixations of subtrochanteric fractures. I invite Dr. Bangarswamy to receive.
So I just add few more points, that is tips and tricks of reduction in management of subtrochanteric fractures. So I'll just rush through with the main slides. So why is this problem in case of a subtrochanteric fracture? It is because of the deforming forces, especially at the fracture site. So you have got a significant muscle bulk in that area which deforms the proximal fragment into flexion, abduction and external rotation through iliopsoas, abductors and for the distal fragment, adductors. So I'm not able to point it out, sorry. So the preferred implants, as I previously told, in stable fractures of proximal femur, DHS, and DHS is the first implant of choice, whereas in unstable fractures and subtrochanteric fractures, PFN is the first implant of choice, followed by trochanteric plate and then DHS. Of course, DCS also is an option. And implant selection is purely dependent on the age of the patient, bone stock and medullary canal also plays an important role in taking a decision of selecting an implant. So if the medullary canal is very narrow, so frequently we may come across a proximal femur fracture where medullary canal is less than 8 mm. So there we may have to choose a plate rather than a nail because you don't have a smaller nails or small diameter nails. So the objectives and keys of success depend on understanding the fracture pattern and deformity, recognize the problem fracture patterns pre-operatively and plan accordingly, have a plan to achieve alignment and make sure fracture is reducible even before you put a knife, and bone contact is the most important thing in all these fractures, even if it is comminuted, and get the entry portal right. That is only after securing the reduction. So have a fracture reduced and take a entry point, which is very, very important. So I'll just, so most of the times these are a comminuted fracture or a transverse fracture or a longitudinal fracture with displacement. So where you can use clamps or spike pushers and judicious use of wires, SS wires. I'll show you one after the other. And nail versus plate, in IM nailing, that is especially in this case proximal femur nail. So inherently it is biological and takes effort to be invasive. So it is, if you properly use it, it is less invasive, whereas a plate so is more invasive than a nail. And most important thing is preservation of blood supply is the key in this management of subtrochanteric fractures. First thing is once you choose an implant, so position of the patient, this is very, very crucial when you take this patient of subtrochanteric fracture to theater. So this is known as a scissoring position, wherein you have a traction on both the limbs. So I'm not able to use my pointer. So even in this case, your right limb is also is having a traction device as well as the left. And in such a scenario, you avoid this, so towards your left you can see a space for the trochanter to allow your nail to go inside, whereas the other side your pelvis is coming onto the proximal femur because of the tilt. So you should use traction on both the limbs, and of course towards the side of surgery you may have to use more traction, and at the same time you should tilt the patient to the other side to accommodate your C-arm during surgery. So like this. So this is the ideal ideal position in case of subtrochanteric fractures. So here is a patient of around 50 years. So most of the times you may get away just with a traction, and traction itself becomes a reduction tool. So this is after the reduction of that particular fracture with a traction, and you pass a guide wire followed by a nail, and then that is the outcome. So entry point is crucial, and preferably you have to enter relatively. If you take a tip of the medial tip of greater trochanter, try to stay few millimeters or 1 to 2 millimeters medial to the tip of the trochanter, and reduction before the entry. So before you take your entry point, so secure your reduction either by using one of these methods, either open the fracture with minimal invasive way and use a pointed reduction clamp, hold the fracture reduced, and then pass the guide wire, like in this case you can see. And at the same time, so if you are right in one particular view and the other particular view is not acceptable, like in the right side picture, so you just choose a guide wire, keep the primary guide wire and take another guide wire, pass anterior to particular previous guide wire, and you will be able to be in right place. So you have got this sleeves reduction, entry sleeves, by which you can have 2 to 4 mm offsets during insertion of your entry points. You can use this particular device, and then you can stay either anterior or medial or lateral with 2 to 4 mm of gap in between the two. So like I told, reduction before the entry point. So if you say in this particular case, spend time on right entry point, which is very, very important in these cases. So if you see a fracture like this, an unstable kind of a fracture, wherein if you pass so the fracture has been reduced with a humans anteriorly, which is the common scenario wherein you have got lift of proximal fragment anteriorly, and then if you start passing, so this is the primary entry, that is even before you start using your guide wire, try to get the reduction, and then this is humans which is reducing the fracture over that area, and then I take a entry point and then start using it. And if you start entering through the fracture site, in this particular case you can see the fracture is going into varus. So spend some time and then do all means and get a right entry point. So in this particular case I have used a humans onto the trochanter, and then I have secured with a another guide wire in the superior part, and I entered with a entry point, so onto the medial side. So that is the outcome, and most of the times you can just get away with the same incision through which you are passing a screw. So you need not open another wound, or you need not take another incision to reduce the fracture. Most of the times it falls into the same incision area to which for which you where you take an incision for your proximal screw fixation. And planning is most important thing. So I'll just show you a case example. Here is a patient operated elsewhere, came to me with this particular picture, has a DHS failed with a subtrochanteric fracture. So So if you see carefully, so here is a place where you don't have a medullary canal at all. So after further investigating, I came to know that this is an osteopetrosis, wherein even if you try to, like, you should have all the armamentarium on the table to go ahead with fixation of this fracture. My initial plan was to go ahead with nailing, but I could not pass any reamer. So I changed my mind on table, which I planned it beforehand. I went ahead with trochanteric buttress plate. So that's how it is, and that is his outcome. So planning is very, very important in these cases. And reduction techniques. So as I told you, the iliopsoas muscle pull can be nullified with a use of pressure at the proximal fragment, and you can choose to use a bone hook like this, or a collinear clamp, which is really expensive, which can also be used. I'll show you a few of the examples here. So nail should not be used as a reduction tool, and hold the reduction and then put the guide wire, which is very, very important. If you take this particular patient, he is around 30-year-old male, has a subtrochanteric fracture. This particular case, this is the lateral view. So try to hold the reduction with a small incision on the lateral aspect, and this is the incision which is same for your screw fixation. And then you start using a guide wire, and that is after, and secure the fixation till you pass the nail as well as your screws into the proximal fragment. So that's how it is. This is final picture. So sometimes you may have to use another entry to reduce it and hold it in place. So that is his outcome after 3 months. Another important point, so you have to see a lesser trochanteric prominence to see whether it is into rotation or what. In subtrochanteric fracture, in this particular picture, you may have to derotate and then only start using your entry point. Otherwise it will be difficult. Here also same thing, you can use a small incision, and most of the time this incision corresponds to your screw incision. So that is after fixation. There was no extra incision. And so here is another example, managed similarly. So most of the times I don't use SS wires. If at all, if you are using SS wire, don't try to strip whole of the periosteum and put an SS wire. It is better if you have a minimally invasive SS wire passer. So few of the examples, and here is another patient. So this is another example wherein there is a fracture, but your medullary canal is less than 5 mm in this case. So better you choose a plate rather than a nail. So this I operated long back. That's one of the pictures. So take home message, reduction is the key in subtrochanteric fracture management. Entry point is the crucial step, and maintain the reduction while reaming and nailing till the screws are put. And open reduction can be biologically friendly. So it can be managed with a very minimal incision, through which you can pass a pointed reduction clamp and hold the fracture reduced, and then pass your guide wire, and which has very minimal muscle stripping. Thank you.
Thank you, Srinivas. It was a very good lecture. Now I request Dr. I. Praveen Rao Garu to come on to the dais and give a